Alright, we're going to do a quick voice-over PowerPoint for you guys for Chapter 46, and this is all about disorders of our integumentary system. I hope you have watched the two other YouTube videos that I have posted for you. So watch those and then take some time and watch this one as well. So all of this starts on page 1153, and the first thing that we're going to talk about are fungal infections of the skin. Now, the first picture that we see here is, let me get my pin up and I'll circle it for you, or at least put a little star beside it. These are ringworm. This one is athlete's foot. And then this one here is fungal infections of the nails. And you can see it's kind of yellowed. We don't have the normal nail shape, connected with the skin there. Yellowed with kind of losing that normal connection there with the skin. So what happens is that top layer of the skin, the keratinized cells, are being attacked. So typically a fungal infection is on the superficial skin level. We can also have deep fungal infections, and this will attack other areas of the skin and maybe even deeper tissues as well, getting into subcu and fat and all of that. Bacterial skin infections, primary infections, what we see are usually superficial infections, and those would be like impetigo caused by staph. And remember that this can cause glomerular nephritis. Secondary infections, infected ulcers, that's this picture here on the left on the bottom here, and you can see the infection is really right in this area here. And then cellulitis, anything that's kind of reddened on this leg here. You'll see cellulitis being swollen, and it's caused by lots of different bacteria. They did list group A strep here and Staph aureus, so those are the most common. The picture up here on the top is impetigo. Viral skin infections, the first thing that you might think of when you think of a viral skin infection are warts, and that would be what is in this first picture here. The second picture listed probably looks fairly familiar to you guys, and that's a cold sore. Remember, this is caused by also the herpes simplex virus there, types 1 and 2, and they will cause different types of infections there. And the third picture here is shingles. And remember, this comes from herpes zoster, which is the chickenpox virus being reactivated. And typically you will only see kind of lines of this. On one side of the body, it's not going to be on the other side. We don't see any of the red lesions on the other side. And so typically it travels down that nerve onto the skin. Very, very painful. And very irritating. So it's even just if you had a shirt on, that would be pretty painful for the patient. So this question should be fairly easy after what we just covered. Which of the following microbes causes warts? Is it fungus? Is it virus, bacteria, or any of the above? So I'll flip it to the next slide. And remember that warts are caused by viruses, and they are benign. They're not a cancerous lesion. So now we have a scenario here, and Mrs. K is worried about her complexion. She says she always has had good skin, but now her face itches and burns on the right side, and there are red lumps on one side of her forehead. So what are the possible causes of this? And you can take some time to look that up. I'll tell you what the possible causes of this one is, particularly for this patient, since it's only on one side of her face and they itch and burn. This is shingles, and you can see it just affecting the face of a patient. You'll see a very clear line down the middle of their face as one side being affected and the other side not being affected. So just keep that in mind when you're seeing shingles. It's not always on the trunk or the torso, but it's also could be on one side of the face. And those lesions they burn quite a bit for the patient, and they can be very itchy. The next topic that we have here is acne vulgaris, and we're pretty familiar with acne. Probably a lot of us at least dealt with this at some sort of stage in our life. We can have non-inflammatory lesions. These are just whiteheads and blackheads, but we could also have inflammatory lesions which become red, pustules, nodules, and even go on to cysts. So we have to remember that this is related to hormonal stimulation of those sebaceous glands. And we see an increased activity in that sebum production, causing kind of that inflammation there. Bacteria will also get trapped in that. You want to teach your patients with acne that they really should not be popping the acne. They should just leave it alone, maybe apply some sort of topical medication that's prescribed by a physician, making sure they wash their face every morning and night, maybe even in the middle of the day if they need to. So allergic and hypersensitivity dermatosis. The first one listed here is atopic dermatitis, and we can see that in the child there to the right with the reddened cheeks. So it's chronic, it's relapsing skin infections. It's very hard to handle sometimes. Your patients can it can get out of hand. So most of the times we do a topical corticosteroid to treat the flare-ups. We may also do some different types of baths for our patients. And you've probably heard of like the oatmeal baths, and sometimes they'll even give baths in baking soda to kind of help with this dermatitis. Urticaria, also known as hives, we see this a lot of times as being kind of an allergic reaction. And they are edematous wheals, and we can see the wheals on the patient here, which are just kind of these small little dots, and I'll circle one of them for you. That's a wheal, and you can see as this progresses, they become bigger and more edematous. And usually this is from the release of histamine. The last one that's listed on this slide is drug-induced skin eruptions, and so a lot of times these patients are very, very allergic to whatever medication they just took. So the patient I have pictured here to the right on the bottom there, his is an example of Stevens-Johnson syndrome, and we're going to get to a couple more slides that are a little more, that give us more explanation about these disorders. So next we have a question here. Which chemical mediator is released by mast cells as part of the inflammatory response? And I'm hoping that this is fairly easy for you. And let's flip over to the answer slide. Okay, so the answer here is A, and I hope that you picked that one out. Histamine is stored in our mast cells. One of the first substances, remember, that's released during the inflammatory response. We see the bronchoconstriction, mucosal edema, and increased mucus production. And when we have that overly active immune system, we can see also hives, coming from that as well. So just to kind of expound on our drug-induced skin eruptions, urethra multiforme, that's the top picture, kind of with the little bullseye rashes there. This occurs after herpes simplex infection, and it is very self-limiting. The next one listed is Stevens-Johnson syndrome. So this one, our patients a lot of times are admitted to a burn unit because of to the degree at which the skin detaches from the body, and it's usually less than 10%, but we see a lot of times the respiratory system being involved with that. So we'll see the detachment happening around the lips and mouth, and even inside of the mouth and the tongue. The last one listed here is toxic epidermal necrolysis, and this is greater than 30% of the epidermis detaching, and there is a 40% mortality rate. So these patients are for sure admitted to a burn unit. You can see here it very much looks like our patient has suffered a burn, having that skin being detached and peeling away. So they're very much treated like they have a burn. We have to protect their skin because they're losing those outer layers. We have to regulate their temperature and all of that as well. Papulosquamous dermatosis. So this is scaling papules and plaques. Probably the most common one that we see is psoriasis. And remember, this is a chronic disorder. It's an inflammatory condition. These are listed starting on page 1164 for you. So a lot of times we don't see these types of issues in warmer climates where they're out in the sun more. And I know that they will encourage patients that develop psoriasis maybe to get out in the sun and kind of absorb a little bit more of that vitamin D to kind of help with that. But we need to be able to recognize and differentiate between the different types of lesions, and psoriasis for sure has that kind of silvery, plaquey type of finish to it, and I think we could all recognize that one. The other three listed here are not going to be anything you're going to be tested over. We just very rarely see them, so we're just going to skip right on over those. So just a little bit more about psoriasis here. This is a T cell that releases those cytokines and the growth factors. We have abnormal growth of those keratinocytes and the dermal blood vessels. So what we see is that redness and then the skin cells growing rapidly. So then we start to see it kind of starting to flake off and peel, and that's where we get kind of that plaquey appearance. So this is something that I think we're all pretty familiar with, UV radiation. Remember what happens is when that UV hits the melanocytes in the skin, we see the melanin starts to oxidize. This is how we see a tan in an individual. So a tan is a sign of skin damage. It's not a healthy sign that we see. The more melanin that's produced, we'll even see delayed tanning, which I'm sure that's what we're all looking for when we go out into the sun. It's kind of that tan that sticks around for quite a while. Some of the UV rays do reach those lower skin layers, and that's what causes sunburns. So we have DNA damage, cell damage, our immune system is decreased when we have a sunburn, and we're going to get to those specifics here in just a little bit. But first we're going to talk about burns. And you guys have probably heard about burns being called first degree, second degree, third degree. But now I want you to think about it in a little different way. I want you to think about a first degree being called a superficial partial thickness burn, which I know sounds a lot longer than first degree, but basically that's the outer layers of the epidermis. Second degree burns go between partial thickness, so only part of the dermis, and a full thickness burns, which is the entire dermis. Third degree is into subcutaneous tissue, might damage muscle, even bone and blood vessels, and that's a complete full thickness burn. So here's a little image for you to help remember the different types of burns. Superficial burns, that would be painful, like a sunburn. No edema, we do have redness, and it blanches with pressure. That means if we put pressure on it, we lift up, it turns red again fairly quickly. It means we still have good blood flow to the area. Partial thickness, we see a blister. It's very moist and painful. This could be like a splash burn, something, maybe some boiling water from the stove, or even a really bad sunburn can cause a partial thickness burn with blistering. Full thickness is dry. They'll have areas of eschar, which is black. Those areas are discolored and they do not have pain. But I want to tell you that every single patient that has a burn is in pain, because the outskirts of a full thickness burn is going to be partial thickness, and the surrounding areas of your partial thickness burn is going to be superficial. So every single burn is painful, although when you get down into the full thickness layers, you have damaged nerves. So that specific spot is not going to be painful, but everything around that will be very painful. So we have a scenario here where Mr. D was boiling water and the pot tipped over on him. He has painful, bright pink, blistering burns over most of his left arm and his chest. How would we categorize this burn? So if we look back at our picture here, he has moist, blistered burn. We can obviously label this as a partial thickness burn, or if you want to go back to first degree, second degree, third degree, this is a second degree burn. And that's how we would label this burn. But if we look at Mr. D's burns, they're pink, but the rest of his body is starting to look pale, and he has a rapid heart rate. His pulses are weak, his bowel sounds are absent, and his respirations are rapid. What do you think might have caused these signs in Mr. D? So if we turn to page 1169, we'll see the hemodynamic instability that can happen with burn. So certain complications of burns, we have hemodynamic instability. It causes a hypovolemic shock in our patients. And a lot of times you'll hear this called as burn shock. So what happens is we have injury to the capillaries in the surrounding tissues, and then we start to lose fluid from the vascular compartments and the interstitial compartments or the tissues. So losing that vascular volume is causing hypovolemic shock. And when we're in shock, we see that increased respiration, we see the tachycardia, and all of the signs from what we had just looked at in Mr. D's scenario. Now, some other things that we should be looking at in our complications of a patient that comes in with a burn is a respiratory system dysfunction. So we need to look and see if there's any obvious signs that our patient had a smoke inhalation injury. And they may have burning of nose hairs, kind of soot around the mouth and the nose. Any sign like that, or any obvious lung sounds that you're hearing, need to be taken very seriously, because they can start to become edematous in their lungs and in their around their trachea, and they can lose their airway very quickly. So if our patient starts to develop something called stridor, meaning kind of that high-pitched shrill noise when they breathe in, we need to probably get them intubated as quickly as possible, or get that breathing tube down their throat. The other thing that we see in burns is a hypermetabolic response, meaning their body is kind of sent into overdrive trying to repair all of the skin cells. So it's working much harder to try to repair itself. We have heat production that's continually being made because we have lost kind of that outer layer of our skin that keeps that heat in. So that is also kind of another factor when we're looking at the hypermetabolic response there. We need to make sure and get food to our patient as they request it, and continually make it available to them. Now, this hypermetabolic state peaks at approximately 7 to 17 days after the burn. So this is going to be a prolonged response that we need to be watching for. Obviously, our last one listed here is sepsis, and we have lost our first defense, or that first line defense of our body's immune system, by burning off at that outside layer of skin. So they are at very high risk for infection and sepsis. So monitoring our patient's temperature, looking and seeing what is colonizing there, doing some different cultures, just to be sure that we're not getting an infection. So now we have a woman who was severely burned, and she has been in the hospital for 8 days. So I want you guys to look into these questions. Why would she be developing an increased urine production? Why would she be having some weight loss, increased temperature, and also GI bleeding? So there's a few paragraphs on page 1170 for you to look through to find those answers. So I want you to take the time and look those up. So treatment for a third-degree burn patient includes all but which of the following? Are we going to do A, fluid replacement, B, removal of dead tissue and eschar, C, antibiotics, or D, aloe? Which one are we not going to include? The answer here is aloe. Now remember, this is a patient suffering from a third degree or a full thickness burn. So we're losing tons of fluid through our skin, and we are very, very high risk for infection. So we must replace fluids, and we need to have those antibiotics on board to fight and prevent infection. Now, dead tissue is called eschar, and that has to be taken off every day, or else that's just going to continue to kind of damage the area. So eschar needs to be removed. Applying aloe, topical aloe, is not going to help this patient. Okay, so we've hit about 20 minutes in our presentation here. If you feel like you need to take a little break, get up, go to the restroom, stretch your legs a little, feel free to do that. I'm going to continue on. You can pause the video and take your break, but I'm going to go ahead and continue on with pressure ulcers. We don't have a whole ton left in this chapter, but if you feel like you need a break at this time, go ahead and take one. So pressure ulcers, we're very concerned about these with our patients that are immobile, pressure on the skin area. So what happens is we have pressure being exerted from an external source, and this blocks blood flow. Now there's another thing called shearing, and you may have already talked about this in concepts where it's so important to use the draw sheet to help lift a patient up into the bed. Now, shearing is where we don't use that and we decide to either grab them under their arms or something like that. And that happens by bending the blood vessels and kind of tearing them. And this is going to cause an ulcer as well. We can also see obstruction of blood flow, ischemia, to the skin. Now, right now, you probably have a pressure 1 or a stage 1 pressure ulcer, and all that is probably from leaning on the table right now with your elbows. If you lift that up and look at your arm wherever you're leaning that on the table, it's probably already showing some signs of redness from that pressure there, so we're obstructing that blood flow there. So tissue damage occurs because of the ischemia to the skin, because it's not getting that oxygenated red blood cell to supply it with nutrition. And it could be that friction or that shearing, which is damaging the dermis and the epidermis there and bending those blood vessels. So this is just a quick picture about staging pressure ulcers. I just want you to get kind of a brief intro. I know our book doesn't mention much about staging, but the first one there on the top left is a stage 1. And so basically all this is, we don't have disruption of the skin at this point, but it's red. It's not blanchable. If we go to a stage 2, we're starting to have some breakdown of the skin there. Stage 3, which is the bottom left, we're down into the sub-Q, so down into the fat. And then stage 4 is all the way down through muscle and down to the bone. So those are very, very hard to heal on our patients. So just a quick intro there on staging pressure ulcers. You'll get more experience with that, though, as you go through nursing school. I was looking up a picture of a sunburn and I saw this guy and I just had to use him, because how many times do we have that friend that looks just like him right there? Looks like he still has his t-shirt on even though he does not. So any type of sun exposure does increase the risk of cancer. Total accumulation of sun exposure increases the risk of basal cell and squamous cell carcinoma. Now, if we have intermittent sun exposure, this increases the risk of malignant melanoma, which is kind of that big, bad, scary skin cancer. So malignant melanoma, what we need to be watching for are those cancers that arise from the melanocytes. It progresses very rapidly, and typically it has already spread to another location by the time we are able to identify that that's what it is. So we want to teach our patient kind of this mnemonic, A, B, C, D, E. So A is looking for asymmetry. With a mole or anything like that, it should be similar all the way around. B, border irregularity, and you can see in the picture there, we want it to be nice and round. We don't want it to be kind of bumpy all around. Color variation, we want to make sure that it's all one color. If we have areas that are very dark and then lighter areas, that's concerning. And then diameter, anything that's greater than 1/6 of a centimeter is concerning. So that's basically the end of your pencil eraser. And then if you start to see a skin lesion or a mole changing, then that's to be concerning. So those are the things that we need to be teaching our patients specifically about. So here are some melanoma lesions. I can't remember if these are in your book. They are. They're in your book on page 1174. And both of these are melanoma lesions. And we can see the rules of A, B, C, and D here. They're not asymmetrical. They both have border irregularities. The colors are not consistent throughout them. And the diameter, we can't tell specifically about the diameter here. But we need to look at, is it bigger than that 0.6 of a centimeter, bigger than the end of that pencil eraser? And I would assume that both of these are, but I can't know that without seeing it in person. There are some different types of melanomas. Some of them grow very rapidly, and most of them do. And they're just basically named by location and how fast they're growing. I'm not going to test you on the specific type of melanoma here, but knowing that melanoma is one of those that we have to diagnose very quickly and recognize because it does spread so rapidly and metastasize very easily. So which type of skin cancer is associated with the worst prognosis? I think the answer here should be very obvious to you, and that it's malignant melanoma. Remember that it does tend to metastasize very early. In kind of opposite to that is basal cell cancer or basal cell carcinoma. It has the best prognosis. Squamous cell has a very good prognosis as long as we detect it early. So teaching our patients about the A, B, C, D, E, of looking at different skin lesions and moles. All right, and that brings us to the end of our presentation here. If you have any questions at all, please be sure and write those down, and you can either email those to me or just bring them to class with you next time we meet.